I'm going to walk through just a few slides quickly that kind of illustrate the data that I think really drove the FDA and the CDC on this. I'll then take it back off screen share. I'll talk about operations and logistics of what happens from here, and then we'll leave some time for questions. So let me try and pull up my screen share. Here we go. Okay. The first slide here is showing the vaccine effectiveness against hospitalization among adults who do have underlying medical conditions compared to pre-Delta, before Delta was the dominant strand, and then after Delta was the dominant strand. And what this illustrates is that the vaccines hold up pretty good with Delta. For people that have no underlying conditions, they actually, on this data, showed a small increase, 97 to 98%. For people with at least one underlying condition, they saw a decrease from 89 to 85% effectiveness. For people with hypertension or high blood pressure, they saw a decrease from 90 to 85% effectiveness. And for people with obesity, they saw a decrease from 92 to 90. So small decreases, but not big decreases. The point of this slide, the reason why this was discussed is there was an ongoing debate about whether the issue is, do the vaccines wean a little bit with time, or do they wean because of Delta? And the true answer is probably somewhere in the middle, but it's clear that it's not Delta alone. It's pretty clear that the vaccine effectiveness does, after a number of months, wean a little bit from what you enjoyed initially from it. This is some Israeli data. Israel has been giving boosters for a number of weeks now, specifically with Pfizer, and has really robust data on it. So a lot of the discussion focused on data that was provided by the Israeli Ministry of Health. This is safety data looking at the rate of systemic adverse events. These are severe adverse events, bad side effects after one's first dose of Pfizer, one's second dose of Pfizer, and then one's third dose or booster of Pfizer. If you look at the box on the right, the third dose or booster, for each of those categories, loss of appetite, diarrhea, lymphadenopathy, abdominal pain, dizziness, nausea, vomiting, chills, myalgia, which is muscle aches, headache, fever, and weakness, they actually saw less side effects after the third dose than they did after the second dose, which speaks to the safety of giving a third dose of Pfizer at this interval. This is some additional data from the Israeli Ministry of Health looking specifically at myocarditis. So myocarditis is inflammation of the heart. This is one of the potentially severe side effects that was discovered in greater numbers after Pfizer had been out there for some period of time. It's one of the more feared side effects in that it does sometimes cause people to be hospitalized, although there's probably many more cases of it that go undiagnosed that are mild. But it is specifically affects younger people as opposed to older people. In fact, younger males are the most likely group to get it, although it's still very, very rare. What the Israeli experience showed is for the first dose, the blue column, you see they saw more reports of myocarditis in males and females, a little bit higher numbers after the second dose in that middle column, but very low numbers in that third dose in that green column. This factored heavily into the risk-benefit analysis. As I'll show you in a second, the potential benefit for these third dose vaccines is the greatest in older individuals. They have the most to gain from it. Younger individuals still have things to benefit from, but not as much as older individuals. So in the younger individuals, you really want to pay attention to what is the risk, and does that risk benefit calculation still hold for younger individuals who were less likely than older people to get really sick with COVID. The Israeli data did not really have very many cases. They had one total myocarditis case after the third dose, which is pretty impressive, really, and painted a lot of the conversation. This slide summarizes the essence of the risk-benefit calculation that took place as they looked at the different age groups. And I'll go through this as best as I can. I want to point out something you'll see on the scenario. There's 3 bullets on the top left scenario, and they're making some presumptions here, some working assumptions here. And they are assuming, for the purposes of this calculation, this exercise, that the risk of myocarditis after this third dose, this booster dose, is double the risk of the second dose. That's a highly, highly conservative estimate, because as we just saw with the Israeli data, it's quite possible that the risk is significantly less than the second dose. So they're erring on the side way of caution and assuming, for the sake of argument, let's just assume the risk is actually double than the second dose. It probably is not. In fact, the Israeli data suggests far from, but to have a really conservative risk-benefit calculation, that's what they went on. I just wanted to point this out. On the top right, you'll see the vaccine effectiveness. That's what VE stands for, against hospitalization for the various age groups. And you can see that the older you get, you have the slight reduction in how effective this vaccine is against keeping you out of the hospital. For people 65 and above, 85% effectiveness is still pretty darn good, but it is 5 percentage points down from people who are aged 18 through 29. So let's get to the meat of this. This looks at the number of hospitalizations prevented, COVID hospitalizations prevented, versus the number of new cases of myocarditis, which is probably the most significant side effect that we're going to consider with booster doses, expected per million booster doses given. So for age groups 18 through 29, for every million doses, every million people that get boosted with Pfizer, there will be 114 COVID hospitalizations prevented. There will be 26 additional cases of myocarditis. For age groups 30 to 49, for every million people boosted with Pfizer, there will be 298 COVID hospitalizations prevented, compared to 6 additional cases of myocarditis. For age groups 50 through 64, for every million people boosted, 488 COVID hospitalizations prevented in 1 case of myocarditis. And for people 65 and above, 2,080 COVID hospitalizations prevented, compared to 1 additional case of myocarditis. Just for comparison, I'll let you know, to date, since the vaccine began in Louisiana, we've had 3 cases of vaccine-related myocarditis here, all 3 of which were in relatively younger individuals, all 3 of which spent a couple of days in the hospital and did okay. No fatalities from them here. This is the essence of where the risk-benefit analysis comes into play. It's very, very clear when you look at this. If you're in the older age brackets, there is much, much, much more benefit to you getting boosted with Pfizer than there is risk. When you get to the younger age groups, it still is likely that the benefits outweigh the risk, but it's a little bit closer of a calculation. And because of that, when you're in the younger age groups, there's more things that we want to consider beyond just your age. We want to consider, do you have underlying conditions? Do you have a occupation that puts you at higher risk for exposure? Do you live in a setting that puts you at higher risk for exposure? Do you have other things that need to be considered, like, do you live with someone who is very, very high risk or immunosuppressed? It's going to be more important for people in these younger age groups if they're not sure about a booster, if they're not sure where they fall in on this risk-benefit calculation, to have that conversation with their doctor who can walk them through it. The last slide I'm going to show talks briefly about equity, because that factored into the conversation as well. And I don't want to discuss anything about vaccines without talking about equity. What you see here is the cumulative COVID hospitalizations nationally, broken out by race and ethnicity, from the beginning of the pandemic, essentially from March up until September 11th of this year. You can see a significantly higher rate of hospitalizations in American Indians and Alaska Natives, a significantly higher rate in Black Americans, and a significantly higher rate in Hispanic Americans. We knew this, it pans out as well in our Louisiana data. The point of including it in this conversation is when we talk about who it makes sense to offer boosters to, if you just go squarely off of age and you ignore underlying conditions, you ignore occupational exposure, then you disadvantage people who are in more marginalized communities, because people in more marginalized communities are more likely to have a job that requires them to be on the front lines. And they're more likely to have a condition that puts them at higher risk of complications. That's why you're going to see the guidelines that have come out deal both with age and with underlying medical condition and with occupational or living situation exposure, so that we don't do anything that further exacerbates the inequities that have already been unfortunately a big part of the pandemic. I'm going to stop the share now if I can. And 1 second. Great. So let me walk through quickly what the guidance is right now, and then we'll talk about how this gets operationalized. On a broad sense, there are 3 groups of people right now who now have Pfizer booster shots made available to them. And this is, in a large sense, anyone who is vaccinated with Pfizer and completed their 2-dose series at least 6 months ago. So if you completed your Pfizer series at least 6 months ago and you are 65 and older, you are now eligible to get a booster. If you are 18 years of age and older and have at least one underlying medical condition, you are eligible to get a booster. And those conditions are the very same conditions that we had talked about earlier on with increased risk for COVID, bad COVID outcomes. They include very common conditions in Louisiana, like hypertension or high blood pressure, like diabetes, and also pregnancy as well. And the third category is if you are 18 years or older and you live or work in a setting that places you at high risk for exposure, you are now eligible to get a booster as well. This includes anyone that lives in a nursing home, anyone that lives in an assisted living facility, anyone that lives in a jail or prison, anyone that lives in a homeless shelter or a dormitory. It also includes anyone whose job puts them on the front lines: healthcare workers, hospitality workers, teachers, and a lot of other individuals who put themselves on the front lines. All of those individuals that I just mentioned, those 3 broad categories, are eligible to get the vaccine, to get the booster, the Pfizer 6-month booster, if they had Pfizer to begin with at least 6 months ago. The CDC went a little bit further, and this is where the language gets a little bit nuanced. If you are in that first category, 65 and above, or if you're 50 and above and have an underlying condition, the CDC is saying proactively, we recommend it. We recommend you to go get the booster. If you are in those other categories, if you're between the ages of 18 and 49 and have an underlying condition, or if you're between the ages of 18 and 64 and have a job or a living situation that puts you at high risk for exposure, you are eligible for a booster. And you're encouraged to have that conversation with your doctor to talk through the risk benefit and whether it makes sense to you. And I think the answer is going to be different for different people. What is their comfort level? What's their home situation like? Who are they around? How risky is their occupation or living situation? There's room for discretion in all of that. Operationally, this goes into effect immediately. So anyone is eligible in those categories to get a booster right now. Now, some vaccine providers, we're talking about pharmacies, hospitals, and clinics, it might take them a day or two to get their protocols up and operationalize this guidance. And so we're asking people, if you're going in to get a booster, particularly in the next day or two, call that vaccine provider ahead of time to make sure that they're ready. But once they're ready, and I think this will happen quickly in terms of the viewpoint of the FDA, the CDC, and the LDH, people are good to go to start getting these boosters right now. Our goal here is to minimize as much as possible any barriers and to make this as simple as we possibly can. There is no need for physicians to write anyone a prescription or to actually sign a referral form. There's no need for people to bring specific documentation of their underlying condition or their job or their living situation. Their age should be enough. There's no need for people to sign any type of self-attestation forms saying that they sign that they are of this particular condition or this particular occupation. Vaccine providers have been instructed to take patients at their word for this. We want there to be no barriers at all, in particular for people that might have challenges accessing care, who might not have a doctor that they can call on immediately. We don't want them to get any barrier if they think the booster is indicated in them. Anyone that has a question, anyone who's not sure if they should get a booster, anyone who's not sure what their personal risk-benefit calculation is, should have that conversation with their doctor. That's the best guidance that we can give right now. We've been assured by the White House that there is ample Pfizer supply on this. We certainly, for the past number of months now, have not come close to using all the vaccine in Louisiana that we've had available to us, unfortunately. So we have plenty of vaccine available. Supply is not going to be a problem here. This at the moment is only for people who received Pfizer, and specifically only for people who completed that 2-dose series at least 6 months ago. There will be more conversation on Moderna and Johnson & Johnson in the coming weeks. And to be frank with you, I expect similar conversation and similar announcement for Moderna and J&J in the coming weeks, but we're not there yet. That will happen in due time, and the FDA and the CDC will go through the same process that they did this past week, have those conversations publicly, and then we will review and issue our LDH guidance. So that's coming. I know a lot of people who got Moderna and got J&J are anxious, and I understand that. My wife is one of those people. That's coming. It's coming very, very soon. I want to assure people that the same safety monitoring system conducted by the FDA, the CDC, and LDH remains in place for these booster shots. So we will be monitoring for any adverse events, any bad side effects. We will continue to be immediately transparent with that. And if we need to make additional modifications or announcements, we will do that as we've done throughout this campaign. The safety is the most important thing, and I think our responsibility to be transparent with the people of Louisiana about what the data is probably the most important thing to keep the trust of folks in Louisiana. And the last thing I'll mention is, just like vaccines to date, this should be 100% free to the patient. They should not pay for the shot, and they should not pay for the provider's time in administering that shot. They are encouraged to give their insurance if they do have it, because the provider can recoup some reimbursement from the insurance. But if they don't have insurance, that's not a barrier, and the feds comp that on the back end. I'm going to pause there. I'm sure there's a bunch of questions. I'll be happy to answer as much as we have time for.
Thanks, Dr. Cantor. Really great presentation. We only have 2 questions right now, so if you still want to get some questions in, we should be able to take them. But let's start with David Gray, if you want to ask yours. I can read David's if he doesn't want to log in. It was that...
I'm here. Sorry, I thought you were just going to read it.
No, go ahead, David.
No, Dr. Cantor, can you explain the difference between this latest approval on booster shots and the one back in August when LDH made the 3rd doses available to people with compromised immune systems? Because I believe
Yeah.
Moderna was in that one as well,
Yeah.
correct?
Yeah, Dave, that's a great question. And thank you for, I should have mentioned it. Thank you for prompting me on that. I'll start with the difference in terminology. I'm going to differentiate between third doses and booster shots, even though I probably didn't do a good job of that in the first half of my presentation. What was announced last month is that people that have conditions that suppress their immune system, we're talking about people that have active cancer and are getting chemotherapy, people that had an organ transplant and so they take immunosuppressant drugs, people that are on chronic high dose steroids. These conditions impair the functioning of someone's immune system. When you have an impaired immune system, you likely don't mount as good a response to any vaccine as someone who is totally healthy does. And so you might not be well protected after just a 2-dose series. Because of that, it was recommended for people that fall into that very strict category. We're talking people that have either moderate or severe immunosuppression to get a third dose of either Pfizer or Moderna at least a month out after getting their first 2 doses. We're calling that a third dose. It's a very small number of people. These folks that have these severe conditions, cancer patients, bone organ transplant patients, they know who they are. They're well followed by docs. It's a relatively small number of people who are pretty sick. They should get a third dose because they need it to mount the same type of immune response that I would mount not having those conditions. That's different from what we're saying now. Now we're saying for a much broader part of the population, because the effectiveness of the vaccine wanes a little bit over time. If you got Pfizer and you're at least 6 months out and you fall into one of those 3 groups I just said, 65 and above, 18 and above with any underlying condition, or 18 and above who live or work in a place that puts you at high risk for exposure, you should get a booster shot. Not because you didn't mount a good immune response initially, but because you probably did, but it probably has weaned a little bit now that it's 6 months out.
Great, thanks. We have a question from KLFY. Brett, do you want to go ahead? The question was, will people need more than 1 booster shot in the future?
That's a great question. I really don't know. The only way to know that answer is just to see what happens with the data. That's how we got to this place, is people follow the data. They recognize that at 6 or 7 months out or so, the level of protection weaned a little bit. And so it made sense to give a booster. I don't know, to be honest with you, if after a booster shot, your level of protection just holds steady for 5 or 10 years, or maybe in a couple of years, it goes down a little bit. It also depends on what the virus is doing. And the situation will be different if, God forbid, 2 years from now, there's a ton of COVID still out there, or if COVID dies down and goes away. All of those things factor in. So I don't know. I can tell you that the same process of following this data and seeing how effective it remains is what's going to carry on through the next months and years. I also don't know what new variants might come our way. As bad as Delta was, at least it was a good match for our vaccines. And the doomsday scenario is when we get an aggressive variant that's highly transmissible, that's not a good match for the vaccines. And if that happens, they might need to quickly develop a booster that is a good match for that type of variant. This is all hypothetical, just to say a lot of things could happen and really don't know yet.
Great, thank you. Liam from the Times-Picayune, did you want to go ahead?
Yes. Yeah, I had a question about the idea about verbal confirmation. There's kind of a clause in there saying that you might be able to use verbal confirmation as proof enough. I'm just wondering if that might cause a bit of a complication for anybody who has Johnson & Johnson or Moderna vaccines, and whether that kind of causes a complication about statistics for people getting the booster shot.
Liam, are you asking specifically, like, is someone going to sneak in when they really shouldn't get it?
Yeah, I guess I was beating around the bush there.
Yeah, look, I mean, I'll be completely honest with you. That's already happened a few times. and it probably will happen again. We need to take people on their word. And I think the objective here is to not create a barrier to anyone who really needs it. And if the flip side of that is a couple of people who are dishonest, sneak in, they do that at their own risk and at their own liability. I'll tell you, there's reasons why people might not want to do that beyond it not being the right thing to do. There's not good data yet to support it. And if God forbid you do have a complication, if you are acting not according to guidance or recommendations, there's a good chance that you lose the ability to recoup compensation from the Federal Emergency Patient Compensation Fund. So there's some checks on there to keep people honest for their own benefit. I'm not naive. If somebody really wanted to sneak in there, it's not impossible to do so, and it already has happened, to be honest with you. But the more important thing in our mind is, how do we reduce barriers for people that need this and want this and should get it?
Gotcha. Thank you very much. I appreciate you.
Thanks, Dr. Cantor. And just wanted to bring everybody's attention to Allie's note. The vaccine hotline is always a great thing to share with your audience, just to make sure that people know that if they have a question that's outside of a discussion like this, they can do that. David, did you want to chime in on FDA, CDC guidance?
Yeah, how you doing? Thank you for the briefing. I guess I'm just trying to get straight. It seems like we got three different things coming at us by third shot versus booster. And I'm just trying to figure out what's the final word, basically.
Yeah, I get it. There's a lot, and it's worth going over a few times. So the third shot for people that are immunosuppressed, that's not news today. That's something that was recommended about a month, maybe over a month ago. Right now, that's out there. That's for people that have conditions that really weaken their immune system. It's a relatively small number of people. These people are pretty sick. They're well followed by docs, and they need a third dose to get the same type of immune response that I would get from the vaccine. And we should think of that as just the initial vaccine series, part of them getting fully vaccinated to begin with. Right now, this is different, and we're saying that because there's evidence that these vaccines do wean over time a little bit, not a lot, but a little bit, particularly because there's still a lot of COVID out there, it makes sense to go ahead and give a booster shot for a much larger group of people, like people 65 and above, people 18 and above who have an underlying condition, people 18 and above who live and work in a place that puts them at high risk for exposure. That's a lot of people. That's a lot of people who initially got Pfizer. So it's a much more expansive announcement than that third dose for immunosuppressed people was a month ago.
So is Walensky's decision final? Is that it?
It is.
That's the decision. Do you know how many people this affects in Louisiana?
It's difficult to say because the definition, particularly of that last group, people who live and work in a setting on the front line, it's not precise, and it does leave enough to be, it leaves room for interpretation. And one of the intents here is to make vaccines available to enough people to merit the response and allow people to have a conversation with their physician to see if the risk benefit is right for them. So it's really hard to put an absolute number on it. I think it technically could include a lot of people. And then I think the younger you are, the more encouraged you are to have a conversation with your doc and talk about the risk benefit and see if it makes sense for you personally.
Thanks, David.
In response to the question about the people sneaking in to get the vaccines in our workflow, we always tell our patients to keep their card, the CDC proof of immunization, and bring it back when they come for their second dose. And we have since been telling them to keep it also for their records. We've always told them that. And should there be a third dose indicated, to bring that card. So when we get a patient that we did not vaccinate and we don't have the records on, we certainly try to determine which one they got so that we can be sure that we follow the guidelines. So I think we would catch those people on our end. I mean, we're human, we make mistakes too, but I think that's a safeguard.
Yeah, I think that makes sense. I mean, I think at the end of the day, we want to err on the side of not boxing anyone out who shouldn't be there, not creating a barrier. That's I think the number one objective here.
So just want to bend the rules one quick time for Laura from NOLA Ready, since they're a great partner agency, as is City of New Orleans. Laura, did you want to ask a question?
Hey, Dr. Canner and LDH team, thanks so much for doing this. I think you covered this, but I just wanted to make sure that the third dose process for Moderna with the attestation form is going to continue as it has been since August.
That's right. Third dose attestation for people who are immunosuppressed is going to continue unchanged. And this today is different. So I know it's a little bit confusing, but third doses for people immunosuppressed, that can happen a month out for Pfizer or Moderna. That's a relatively small number of people. 6-month booster shots for Pfizer require no specific signed attestation.
Great, thanks, Laura. I think that does it for our questions. Did you want to close this out, Allie?
Sure. Just thank you, everybody, for joining us. Thank you, Dr. Cantor. If you all have any follow-up questions, please let us know. Follow up with me and Kevin. I see David already has a follow-up question. David, we'll sneak in this last one before we go. He says, what about students? Dr. Cantor, do you want to take that?
Yeah, I'm assuming you probably mean college students, because we're talking about 18 and above, but there's probably some high schoolers in there. So, they might qualify by a couple of mechanisms. If they have an underlying condition, and many younger individuals do, they qualify here if they had Pfizer 6 months ago, or if they live in a congregate setting, if they live in a dorm, they qualify as well. Now, because they're on the younger age bracket, the risk benefit analysis is still in the favor of booster, but not by the magnitude that it is with older people. So they would do well to talk it over with their docs about whether it makes sense for them. I think a lot of people, the answer would be yes. But if they fall in those categories, if they're 18 and above and have an underlying condition, or if they're 18 and above and live in a congregate setting, they're included in this.